All right. These are my simple info. I'm Dr. Bassam Hassan. I am graduated from University of Jordan, the class of 1981. Currently, I'm the Director of Infectious Disease for Graduate Medical Education, Washington University Medical Center. We have a small residency program and it's in infancy. This is our 3rd year. So this is my email if anybody wants to contact me. Okay?
Yes, sure.
So what I'm going to be doing today is really what I do with my residents. So we're going to have an overview of antimicrobials. I hope all things go well. How is your internet connection? Is it good? Hello? Okay. As you all know, antimicrobials are a treasure for humanity. We should do everything to preserve them. Is this true or false? Okay. I guess it's true. When it comes to antimicrobials, there are really certain basic principles that every physician should know. And from my perspective, I approach the subject in a very simple way. First of all, we need to know the mechanism of action. Second, the mechanism of resistance. And most importantly, for each antimicrobial, we need to understand the spectrum. Understanding the spectrum facilitates really your approach to any bacterial infections. So there's multiple mechanism of killings: cell membrane, blocking DNA and RNA, attacking the 30th and 50th ribosome, folic acid synthesis or cell wall. As far as mechanism of action, cell wall synthesis, as you all know, beta-lactams, cephalosporins, penicillins, carbapenems, and aztreonam are the main actors against the cell wall, as well as glycopeptides represented by the famous vancomycin. The cell membrane synthesis is daptomycin and polymyxin and colistin. I don't know which antibiotics you have in Palestine, but I am sure you are familiar with these. Folic acid synthesis is represented by the good old trimethylsulfa sulfa, Bactrim, DNA RNA inhibition, the fluoroquinolones, metronidazole, and rifampin, the 30th ribosomal subunit, tetracyclines, and aminoglycosides. And the 50th, linazolid, tidizolid, chloramphenicol, which is out of the formulary in many places, and the Sinercid, clindamycin, and the microlides. This slides, it's kind of as a simple quiz. Is there any participants from the audience or just me talking? Okay. I can hear you.
We are hearing you very well. We are hearing you.
Okay, methicillin sensitive Staph aureus. Any choices from column 2?
Methicillin. Last choice. Methicillin. Last one.
What else? Okay. All right. MRSA.
Vancomycin.
And excellent. Vancomycin resistant enterococcus. Which one? Dapto and linazolid. Excellent. Pseudomonas,
Pseudomonas, CRO, 60
I know that Tezosin. It's Piperacillin tazobactam. We call it zosin here. Stenotrophomonas. This is highly resistant microorganism. It's kind of opportunistic, you know, affects immune compromised patients and sometimes colonizes wounds. Okay, there's not too many antimicrobials really that can kill this microorganism, but Bactrim usually is the drug of choice. Sometimes it is susceptible to the fluoroquinolones like ciprofloxacin. ESBL, E. coli, extended spectrum. Excellent. All right, bug and drug coverage. This is a general overview. We're going to go into more details in a bit, but when it comes to the penicillin,
gram-positive anaerobes.
Excellent. Some anaerobic activity. Ampicillin and amoxicillin.
The same.
Excellent. Hey, you are beating my residents. The above ones plus the beta-lactamase inhibitor. It's like amoxicillin glavulinate.
Gram-positive anaerobes, and I think maybe MSSA.
All right. NAF and OXA.
MSSA, gram-positive.
Piptazo.
Positive, negative. Pseudomonas,
What about aztreonam?
gram-positive.
Aztreonam. One by one, please. Who said gram-positive? Please forget that. Never say that again. All right. Aztreonam has no gram-positive activity. It's pure gram-negative, period. That's it. And Pseudomonas, of course. Vancomycin. Okay. Imipenem and meropenem.
Gram-positive, gram-negative. Pseudomonas, anaerobes.
So this is for all, right? But no MRSA, remember. Vancomycin, the only indication, or okay. There's one exception for the carbapenems, which is the ertapenem.
Ertapenem, Pseudomonas, does not cover.
What? Does not cover what?
Pseudomonas.
Excellent. Come and join us. Vancomycin.
Gram-positive, MRSA.
Basically, you know, these antibiotics most of the time are reserved to treat MRSA, right? So we have other choices for the other gram-positives. All right, excellent. Okay, tetracyclines.
Atypical. Gram-positive.
Okay. Really, they have a kind of a broader spectrum, these antimicrobials, but you know, we limit them for certain disease entities. Aminoglycosides.
Negative, gram-negative.
Okay. Do we really advise to give them any gram-positives?
No.
Even if you see it on the sensitivity panel, resistance really develops so quickly, so it is not advisable, and we never use them alone. Macrolides.
Atypical, gram-positive, and atypical.
Okay. The atypicals really, this is like a misnomer. The atypicals are the microorganisms that do not respond to beta-lactams in general. What about clindamycin?
Gram-positive, MRSA.
Which MRSA? Who said MRSA? That's correct, but which MRSA? What kind of MRSA you have? We have a long way to go. Maybe we'll go beyond the 8 o'clock, so because of the delay. I'm gonna consume my time.
Really, we don't know.
What is that?
The freedom of the toxins.
Okay. It's a gram-positive only, right? And some anaerobe. When it comes to clindamycin, remember one thing. For the anaerobes, above the diaphragm.
Yes.
Use it below the diaphragm because of increasing resistance from Bacteroides fragilis. So the drug of choice for below the diaphragm for anaerobes when you need to use it is metronidazole. But for the MRSA is the community MRSA, C MRSA, okay? Not the hospital-acquired MRSA, which is more resistant, and both they really behave in a different way when it comes to infectious process. The quinolones.
Levofloxacin, atypical, positive, atypical, negative, and Pseudomonas.
What else of fluoxetine? Quinolones, they are not all the same, right?
Moxifloxacin, anaerobes, but without Pseudomonas.
No, really, it covers Pseudomonas if you want to, in general. But when it comes, Cipro is a better coverage for, we'll come to that later, for gram negatives. Levofloxacin is better for gram positives than gram negatives in general. And moxifloxacin has one additional activity, and that is
Anaerobes.
anaerobes. Okay. But really, can you use it alone for intra-abdominal infections? It is not really a universal anti-anaerobic. We should always, with these antimicrobials, add flagell if we have to use them for intra-abdominal infections. Metronidazole, anaerobic, and sulfa has some kind of extended spectrum like gram-positive, MSSA, MRSA, but when it comes to sulfa, really only for skin and soft tissue. We never use it for bacteremia caused by any Staph aureus. Remember that. Cephalosporins, spectrum, third generation.
Next antibiotics.
I can hear you well.
Yeah.
You know, the cephalosporins, the spectrum is really differs from one generation to another. The third generation represented by cefazolin, gram positive and some gram negative, not all of them. Second generation has, I'm going to speed up a little bit here. Some anaerobic activity. Third generation represented by ceftriaxone and ceftazidime and cefotaxime. And we have some others here. You know, between ceftriaxone, ceftazidime has additional activity against Pseudomonas, but ceftriaxone has a better gram-positive activity than ceftazidime. Cefepime, that really is replacing ceftazidime, and certain institutions where it is a drug of choice for neutropenic patients because it has a better gram-positive coverage. Ceftaroline, have you heard about ceftaroline?
Yeah, it's more coverage of MRSA.
Excellent. Come and join us. All right. These really some of the newer antimicrobial where they added extended spectrum beta-lactamase inhibitors to treat some serious infections. We're not going to go through this. As far as the duration of therapy now, we tend to decrease the duration of therapy. Just like community-acquired pneumonia, looks like 3 to 5 days they are as good as 10 to 14 days. So the duration of treatment has been reduced. Okay, when it comes to antimicrobial groups, beta-lactams from the penicillins to the, what do you want to call it, fifth or sixth generation cephalosporins, what they share the beta-lactam rings, as you know, and all of them has potential for causing seizures and allergicinity. This is a question. 21-year-old male presents with sore throat and fever. Sedative pharyngitis, tonsillitis, tender cervical lymphadenopathy, rapid strep test is positive. Gives history of non-urticarial skin rash from pain VK, prescribed for sore throat in high school, and told he was forever allergic to penicillin. If the diagnosis of strep pyogenes pharyngitis, which treatment would you recommend? Third generation oral cephalosporin, clarithromycin, PNVK or amoxicillin, or trimethoprim sulfa. This, for the audience. What?
B, clarithromycin.
Why?
ما عنده penicillin allergy. This patient has penicillin allergy. Alternative.
I want you to change your idea or approach to penicillin allergy. In fact, you still can give them penicillin. You can give them VK or amoxicillin. Everybody says I'm penicillin allergic, but the truth of the matter is this. From recent studies, positive history is 10% in the US population. I don't know what is the situation in Palestine. After testing, less than 10% of total at risk for IgE-mediated acute reaction. Penicillin IgE antibody disappears after 10 years. So this is a new finding, and really we are practicing this, especially me. A cross-reactivity in patients truly allergic to penicillin, less than 5% if challenged with cephalosporin, less than 2% if challenged with third or later generation cephalosporin, less than 1% if challenged with carbapenems or aztreonam. Really, when somebody says I'm allergic to penicillin, you have to know when this happened, how long ago, and what type of reaction really. If it is a type 1 reaction, IgE mediated, then you have to find an alternative therapy. When it comes to, that question is that question is trying to tell you. Something happened like 10 years ago, maybe doesn't count at this time. And group A strep, we really like to treat it with penicillin, especially in your part of the world, because to prevent rheumatic fever. The other medications really do not prevent rheumatic fever. Well, the type of allergic reaction in the beta-lactams, the immune-mediated allergic reaction, reaction type, type 1 beta-lactam binds to membrane-bound IgE on mast cells, causing urticaria and genetic edema and anaphylaxis, as you know. Type 2, antibody binds to cell surface, drug antigen causing interstitial nephritis, hemolytic anemia, neutropenia, thrombocytopenia. What are the common features of beta-lactams? They are all bactericidal, all right? They work on the cell wall. The problem with the beta-lactams, there is no post-antibiotic killing, which means that for the antimicrobial to work, the concentration has to be above the minimum inhibitory concentration. Some of them are highly bound to proteins like ceftriaxone and the semi-synthetic penicillins. The major mechanism of resistance is enzymatic, target change, pore enclosure, and efflux pump. Now, if I ask the question, which type of resistance is considered the high resistance, and which one is the lowest resistance? Yeah. When you say this is highly resistant versus low resistance. High resistance when there's a target change. Low resistance when the resistance is due to efflux pump. Because with the efflux pump, you still have some antimicrobial inside the cell, all right? I have another question for you. Drug-drug interaction with the beta-lactams. What drug-drug interaction you know when it comes to the beta-lactams? Anyone? It's not a tricky question. When it comes to beta-lactams, they are the least to have drug interaction, okay? Drug-drug interaction, except one, which is the dicloxacillin, the oral semi-synthetic penicillin. And apparently it increases the clearance of coumadin. The carbapenems reduce serum concentration of valproic acid. If somebody, you know, is on these medications, we have to be cautious. But in general, when it comes to antimicrobial, they are the least to have drug-drug interaction. Now, the semi-synthetic penicillins, nafcillin, oxacillin, dicloxacillin, which one you have there in Palestine?
We have oxacillin.
Which one, nafcillin?
Oxacillin.
Okay, all right. What is the most important aspect of these semi-synthetic penicillins? You know, we use them in just maybe one situation when you have methicillin sensitive Staph aureus, right? In a non-allergic patient. What is the main characteristic of these antimicrobials?
We didn't hear the question.
The question is as follows. When it comes to their pharmacodynamics, something about them. That's why you have to give them in high doses. This is another clue. They are protein bound, okay? 95% protein bound. So the free drug is limited. So that's why you have to give them in high doses, especially with somebody with bacterial endocarditis. So usually the approved dose is 6 grams, but really you have to go up to 12 grams a day to achieve proper MIC for these antimicrobials. And the mechanism of resistance really just changes from protein binding protein 2 to protein binding protein 2A, which is the target change, controlled by the MIC-A. You know, this is usually one of the questions you encounter in the board exams. Special toxicities. Each one of these antimicrobials has a specific side effects. Allergy to include interstitial nephritis. Additional unique toxicity is hypersensitivity hepatitis with oxacillin. Nafcillin, 2 to 3 weeks down the road when the patient is on this medication, like you're treating methicillin sensitive staph endocarditis, right? Native valve endocarditis. We're not talking about prosthetic valve endocarditis. You have to monitor really the blood count when you see neutropenia after maybe 2 to 3 weeks of therapy. What happens here is what they call is the maturation arrest in the bone marrow caused by NAF cell, and then you have to stop the drug and find an alternative. Although this is reversible, but re-challenging the patient with the same antimicrobial will cause the same problem down the road. All right, you have a 22-year-old pregnant female, intravenous drug user, has tricuspid valve, MRSA endocarditis, complicated by multiple lung abscesses, MRSA in vitro susceptibilities, Vanco 0.5, Dapto. Let me take this from here. Is 1.0. Vancomycin therapy, trial concentration 17. Persistently febrile blood culture drawn on day 4 of Vanco, positive on day 6, and vancomycin now is 2. Dapto MIC remains low at 1. Which of the following would you recommend? Continue Vanco and add rifampin and the low dose gentamicin. DC vancomycin start Dapto. DC vancomycin start linezolid. DC vancomycin and start telavancin. This is one of the neuroglycopeptides. 10 milligram per kg q 24 hours. What do you think you should do in this situation?
Vancomycin should be stopped. MIC2 is high, so we should stop vancomycin.
It is high, it is borderline, it is not really that high. It is not above 2, it is 2.
There is no response.
Recommended below 1.5.
If MIC is 1, we can assess the clinical response of the patient. But if it is above 2, we should find another choice.
Yes.
Which day? How long do you think it takes for vancomycin to clear the bloodstream when it is MRSA? The woman is pregnant, right? You think you can? Just think about it from that perspective. She is pregnant, so you are limited to what you can give this patient, right? Can you give her linezolid?
No. No.
Yes or no?
No.
No, why? It is good for MRSA, right? Why we cannot give it? Why not A? Continue Vanco, add rifampin, and low dose gentamicin.
It's a native valve.
What?
Native valve.
It is native valve. Excellent. Thank you. With native valve, we only use single agent. Excellent. Excellent answer. Come and join me. Would you see Vanco start Dapto in this patient who's pregnant? 2 is really borderline. What happens with MRSA, it takes really time for the vancomycin to clear the bloodstream, okay? There's no need really to change the Vanco. There's no need to add any other antimicrobial. Sometimes you have to look for another distant focus of infection, but really patients here is as long as there is no complications, you can still continue with the vancomycin. You don't need really to switch in this case scenario. Telavancin is not approved for bacteremia. It is only for skin and soft tissue infections. Okay, linezolid is bacteriostatic. You cannot use it in this case scenario. So really, you don't have to rush and stop the vancomycin, although it is 2. If it is above 2, you're stuck. Now you have to change it. It is slowly bactericidal. That's why. So patience is the essence here. Okay. You know, the spectrum of vancomycin is limited to gram-positive cocci, of course, aerobic gram-positive bacilli, Listeria monocytogenes, although we don't use it much because we have other alternatives. Corynebacterium jacum. Where do you see this microorganism usually? In immune-compromised patients with central lines, selected anaerobic, especially Clostridium difficile. Vancomycin cover most of the Clostridia species. One of the most common side effects of vancomycin is the red person syndrome. You know, they call it different names, but here in the States, you have to be politically correct. Now they call it red person syndrome. How this happens? Anybody?
It was given
Have
fast.
you ever seen it? Have you ever encountered that? And
Yes.
what is the course of action?
It was given fast, rapidly.
When it is given fast, and it is usually due to activation of mast cells and release of antihistamine. What is the remedy? What do you do?
Stop the infusion.
Okay,
Maybe we can give antihistamine.
excellent. And what is, I'm gonna correct the order.
Slow infusion. Re-infuse.
Okay, you don't stop it. This is really not real allergic reaction. So there's no need to stop the vancomycin. You have to explain what happened to the patient and correct the order and give it at a slower pace. Okay. You know, there's other side effects for vanco, thrombocytopenia, nephrotoxicity, especially when it is given with other antimicrobials like the aminoglycosides or patients in diuretics. These are the other newer antimicrobial, telavancin. It can cause teratogenicity. Personally, I never used it. They are very expensive. They are preferred for outpatient. When somebody comes to the emergency room with the skin and soft tissue, they are drug abusers. No need to admit them. You just give them one dose and send them home and see them in a week. Daptomycin, there are two things we have to worry about. Potential muscle toxicity. You check the CPK and biweekly. You know, we have patients that go home on daptomycin for weeks for osteomyelitis or for VRE, you know, etc. And you have to really worry about, it is a rare complication, eosinophilic pneumonia, that patients come with shortness of breath, cough, and bilateral interstitial. Maybe I have seen one case, but this is something you have to worry about. I don't know. Do you have Dapto in Palestine?
No.
Yes or no?
No.
It comes handy when you are pushed to the wall and you have to use alternative to vancomycin. Cephalosporins in general. Okay, first, second, third, fourth, fifth, sixth, whatever. As we saw the other slide that we spoke about the spectrum, they are not all the same, as you know. A 27-year-old male who is otherwise healthy present with acute appendicitis and hypotension. At surgery, appendix is ruptured and severe fecal peritonitis is present. The hospital has run out of piperacillin tazobactam. In addition to crystalloid fluids and norepinephrine, which one of the following regimens offer the best combination of safety and efficacy? Diazepam, avibactam plus metronidazole, ceftriaxone, tazobactam plus clindamycin, ceftazidime plus tigecycline, cefepime alone. I don't know what. Have you heard about tigecycline?
Yes. Yes.
Okay, all right. It is minocycline with some extra ring. Okay. Or cefepime alone. What do you think?
A.
A, excellent. So whenever you use cephalosporin, whether they have extended spectrum beta-lactamase inhibitor or not, you have to use metronidazole. This is an infection below diaphragm, remember, not clindamycin. You know, this brings us to the enzymatic resistance against the beta-lactams, the extended spectrum beta-lactamases. I am sure you have an idea about these, and we're not going to go through it. We have to really proceed. Adverse effects of cephalosporins. I want to ask you a question here. Have you heard about akinetic seizure? And which drug causes that? If you use that antimicrobial enough, you will see it. Akinetic seizure. The patient is awake, he's looking at you, but he cannot move the extremities. It's simple. And the patient has been on certain cephalosporin for a while. This is a board question, to be honest with you.
I think CPB.
Excellent. So one of the adverse effects are allergy, seizure, Clostridium difficile colitis, and when it comes to ceftriaxone, the pseudo cholelithiasis. What ceftriaxone is mainly is 100% excreted by the liver, and it causes certain crystals. So if you give somebody ceftriaxone in high dose, you do an ultrasound, you will see some sludge in the common duct or in the gallbladder. And some people lost their gallbladder on the impression that they have acute cholecystitis. So you have to be careful when you give ceftriaxone, especially in a patient in the ICU. They are on the vent, they are sedated, they develop new onset fever, they've been on ceftriaxone for a while. Just assess them carefully. They might end up having a calculus cholecystitis. Did we see that? Yes, every now and then. And sometimes it is a lifesaver to recognize this problem. How frequent you see C. diff?
No,
Huh?
no.
Enough?
No.
I can't hear you. Okay. You know, this slide represents what is the most common cause of C. diff, especially here in the States. Maybe worldwide, because quinolones have been used extensively. It is in a reverse order. Clindamycin was the first when the pseudomonas colitis was described. Now clindamycin is being used less and less. It depends really on the country. So fluoroquinolones now, they are taking the lead as far as the for Clostridium difficile. Okay, I have a question for you. A 65-year-old male has recurrent obstructive nephropathy, chills and fever. He started on empiric ciprofloxacin. The laboratory reports E. coli in blood and urine. The E. coli is resistant to cipro, cefazolin, ceftriaxone, S2, gentamicin. Patient has no history of drug allergy. With this pattern of resistance, which of the following is your preferred therapy? Peptizo, meropenem, polymyxin B, or tigecycline? Which one?
B.
B. Guys, I don't really need to teach you or give you a lecture. You're doing great. Why not Peptizo?
beta lactam resistant.
in vitro, it's
Who's that? Who's talking? Who's talking? What's your name?
Evan.
Okay. In vivo and in vitro. Explain to us, please.
In vitro, it's not resistant, so you can use it in vitro. But in real life, it's resistant to Tesla.
Excellent. So if you hear yes, we are producing gram-negative bacteria using meropenem. Carbapenem is the treatment of choice. Every other beta-lactam is being hydrolyzed. Cefepime only potentially stable, extended spectrum cephalosporin. Piperacillin, tazobactam, discordance, active in vitro, and it is inactive in vivo. There's failure of therapy. Excellent. You're making my life easy. Astrinam monobactam, only beta-lactam with no activity versus gram-positive bacteria, like strep pneumo. Safe in patients with severe IgE mediated. The only time there is cross-reactivity with ceftazidime because they share similar chemical structure. So if the patient has type 1 reaction to ceftazidime, avoid astrinam. When there's in vitro resistant of gram-negative, it is a phenotypic marker for the production of ESBL enzymes. Stable in presence of metallocarbopenase. You know this DILI agent, so they use it in combination with other beta-lactams to treat this kind of infection. 60-year-old non-COPD and congestive heart failure admitted with community-acquired pneumonia. Diagnostic bundle performed, and then empiric ceftriaxone and azithromycin started. Within 24 hours, influenza A strep pneumo detected in airway. Oseltamivir started. AKG non-specific ST abnormalities, QT is 440 milliseconds. Atrial fibrillation with with amiodarone, haloperidol PRN for mild delirium, and furosemide for congestive heart failure. On day 2, torsadipine, then fatal cardiac arrest. Which one of the following was the most likely cause of the fatal cardiac arrhythmia? Amiodarone, haloperidol, azithromycin, occult coronary artery disease, influenza myocarditis, furosemide-induced hypokalemia.
Yeah.
Excellent. So prolonged QTC and risk of macrolides and fluoroquinolones can be congenital or acquired. Use caution if family history of unexplained sudden death. You know, when you prescribe these medications, if there's any history, you have to be careful. Electrolyte imbalance is really another crucial component to add to the problem. Concomitant drug-drug interaction and cumulative drugs that inhibit the cytochrome P, underlying non-cardiac disease. You can find the list on this, but it's not important. Current macrolides, azithromycin, clarithromycin, erythromycin. Telithromycin not marketed because of its severe side effects, especially causing hypoglycemia. Other macrolides, fidaxomicin, do you have it for C. diff? I don't think so. This is very expensive medication. I really don't even like to use it. And spermicin for toxoplasmosis. All right, when it comes to the macrolides, one of the most important thing is to understand their side effects. Which category of patients you would like to avoid these medications? Really, it's contraindicated to give it to certain patients. Patients with certain neurological disorders.
Read the question, please.
Which one?
Read the question, please.
I can hear you. Myasthenia gravis, because blockade of acetylcholine receptor.
Yes, and the
Worse than myasthenia gravis, it causes blurry vision, hepatotoxicity, hearing loss, QT prolongation, drug-drug interaction. This medication has a lot of drug-drug interactions, so we have to be careful when we use them. But there's certain differences. I'm sure you can look it up, and you can, I'm sure you have a general idea about it. I'm really dealing with very smart docs here. So okay, linazolid. Do you have linazolid in Palestine?
Yes.
Excellent. All right. Why is linazolid not useful as empiric therapy for COPD patients?
No acidity in the mind.
Can one speak, please? Which one?
No, I think
The answer is simple, has no gram-negative activity, right? So somebody with chronic obstructive pulmonary disease and exacerbation, the most common microorganism, Moraxella catarrhalis, it's flu, Legionella, Mycoplasma, but mainly Moraxella catarrhalis and H. flu. And linazolid has no gram-negative activity, right? So it is all gram-positive. So we don't use it for COPD and exacerbation. Linazolid, which is the trade name is Zyvox, inhibits synthesis of toxic shock toxins, strep, and the staph. The good thing about this antimicrobial, it is bioavailability. So 100% bioavailability when given orally. So it really comes handy when you treat skin and soft tissue infections. It is bacteriostatic, so we don't use it for bacteremia in any case scenario. It causes mitochondrial toxicity 2 weeks down the road. You have to check the blood count, and usually it is reversible. It can cause lactic acidosis because really it works on the mitochondria, and it can cause peripheral neuropathy. The peripheral neuropathy usually is reversible, but if this medication is given for extended period of time, you have to be very careful. You have to assess the patient at least every 2 weeks. And optic neuropathy, it can be disastrous because it is irreversible. Okay. When it comes to drug-drug interaction, what case scenario you should avoid linazolid?
SSRI, I think.
Excellent. Okay, I don't have to go further, guys. You know, excellent. And the new release is tidozolid. The good thing about it, it is once a day. It is more expensive, like 200 milligrams once daily, IV and PO. We use it for MRSA. The main real user is skin and soft tissue infections. The difference between this one and Zyvox is the bone marrow toxicity, but if you give it long enough, at the end of the day, they will both have the same side effects. So nothing really further to say about this. Clindamycin spectrum, gram positives, no gram negative activity. All right. The problem with it is increased resistance with Bacteroides fragilis, so it is not preferred for infection below the diaphragm. It uses strep, group A, B, C, D, etc., MSSA, community-acquired MRSA, hospital-acquired MRSA, but really is not the drug of choice, anaerobes above the diaphragm, actinomyces, fusobacterium, and piptostreptococci. Tetracyclines. Can anybody give me the spectrum of the tetracyclines? I can hear. I think we have some audio issues here. Or clinical uses: spirochetes, rickettsia, ehrlichia. I know these disease entities, you don't see them in Palestine, but once the spring hits us and the ticks are active, we see tick-related illnesses like Lyme and Ehrlichia, rickettsia, the atypical pneumonia like Mycoplasma and Coxella, STDs, non-tuberculous mycobacteria, nocardia, brucella. I'm sure you are experienced with brucellosis, tularemia, Whipple, malaria, Wolbachia. What is Wolbachia? Wolbachia. It is a filarial symbiote. So if somebody has filariasis, usually they add doxycycline to kill the Wolbachia. If you kill the Wolbachia, you get rid of the filaria because the filaria depends on the Wolbachia. It is, they live in a symbiote relationship. Of course, MRSA, somebody has simple skin and soft tissue infection, it comes handy in outpatient. But, you know, what is the main side effects of doxycycline? There's two things really you need to tell the patient before you start writing that script.
Photosensitivity, photosensitive skin rash.
Excellent. And what is the other one?
Bills induced esophagitis.
Excellent. I don't need to teach you, really. You're great. Making my life easy. So photosensitivity, but you know the instructions, no UV light exposure, sunscreen, and this goes beyond 2 weeks after the last dose. So this is something you should warn the patient. So if they finish the medication today, doesn't mean they are out of the danger. They have to wait at least 2 weeks before they resume a normal exposure to sunlight. Hepatotoxicity, teeth discoloration, this is well known, this is basic. Have you seen pseudotumor cerebri with this doxycycline thing?
We heard about it.
Have you seen it?
No.
Maybe back in the days when I was at University of Jordan Hospital. So, and the Jewish Alzheimer reaction, I'm sure you know, all know it, and the pseudotumor cerebri. Okay, name antibacterial classes that demonstrate concentration-dependent killing and long persistent post-antibiotic effect. Okay, aminoglycosides, dapto, and fluoroquinolones are almost the only antimicrobial that have post-antibiotic killing, which means it's not like the beta-lactams, the concentration has to be above the MIC to kill, but when the concentration go below the MIC, the killing stop, except for these three groups of antimicrobials. Okay, prostate. Which classes of antibacterials achieve therapeutic level in the prostate? Only fluoroquinolones and trimethyl sulfa. The other antimicrobials, they really do not reach enough levels in the prostate to treat acute or chronic prostatitis. So these are the good choices. Unless you demonstrate resistance, then you have to use other groups for a prolonged period of time.
Doctor, excuse me, the room is not available after 5 minutes.
Excuse me?
The room for the lecture is not available after 5 minutes.
What is it?
The room we are having the lecture in is not available after 5 minutes.
I can't understand what you're saying.
We don't have the room after 5 minutes for the lecture.
Okay.
We can take another lecture or we can continue in 5 minutes.
No problem. You know, left just with the miscellaneous, let's put it that way. Clinical uses of gentamicin, chopra, amikacin, streptomycin. These are never used alone. They're always in combination. We don't use them purely for gram-positive, okay? Aminoglycosides, plaque, tularemia, brucellosis, Bartonella, endocarditis. One thing you have to know about the aminoglycosides, divided doses versus once a day. The once a day advantage is it gives the renal parenchyma and the cochlear system, vestibular system to clear the drug with the remaining time interval versus if you give it on divided intervals like Q8 hours with normal renal functions, you have accumulation of the drug in these two organ systems that can cause toxicity. That's the advantage of giving it once a day to decrease toxicity. We do the serum level, peak level to ensure efficacy, trial level to minimize risk of toxicity. I'm sure you are familiar with this. Rifampin is the master of drug-drug interaction. It is never used alone, always in combination. It has the propensity of digging deep into the biofilm, especially when you are dealing with prosthetic valve endocarditis and other prosthetic infections. Bottom line, native valve endocarditis, no, we don't use it. We use it with prosthetic valve endocarditis as part of a combo, meningococcal prophylaxis, Cipro or ceftriaxone, tuberculosis, brucellosis as part of combination therapy. And it is the father of all drug-drug interactions. Yeah, so rifampin is the winner. Sulfa, I'm sure you know all about it. I'm not gonna really dwell into that. Nitrofurantoin, the only use is young females with cystitis. It is not encouraged to use it in the elderly. It can cause fever, interstitial pneumonitis, and other side effects. Metronidazole, I'm sure you use it more than we do. Side effects, metallic taste. It is really not advisable to use it in the elderly because of CNS problems. And what is this bird? What is this bird? Hummingbird, thank you. All right. Okay, all right. I'm gonna go back to slide 1. I wanted to copy my email, guys, okay? Let me tell you something. I would love to help. We have a small residency program here.
What's Dr. Redent here?
Okay, this is my info, this is my email. We have a small residency program. We try to be as diverse as possible. We take 8 residents every year. I am part of the faculty, okay? And I do most of the interviews. If I can get one person from either side of the river a year, this is a success for me. So I know you guys, you have a lot of ambition, and I would love to help as much as I can. and you can send me suggestions on my email for any lectures you like to hear. I'm really dealing with a very smart group of residents. I'm really proud of you. So this is my email, and I can go back and schedule something. It takes months to schedule such lectures because it looks like you have a lot of participants here, and I'm glad to hear that. I'm very happy to help.
Thank you, Doctor. It was very, very interesting. For sure, we will arrange for another lecture because it was very interesting. Excuse me, can we have the lectures? This lecture, the slides.
I can look and see what is the availability. I have to go to work. I'm sorry, I look tired. We are overwhelmed with the COVID. So I really apologize if I was slow at certain times, but
No, thank you, Doctor. It was very, very interesting.
I wish you all the best, and this is my email, and I really like to help you guys. I'd like to have some of you here. Please don't hesitate. There's a lot of places here where you can do your specialty and subspecialty, and just let me know, okay? Just copy my email. I'm going to give you another minute. All right.
Thank you so much.
All right.
Thank you.
I'll go back again and see when I can schedule. But if you don't give me a suggestion, then I have to choose. You want to talk about endocarditis? You want to talk about anything? These are one of my favorite subjects. The antibiotic talk is one of the most difficult ones, by the way. Everything else is very easy. Okay, and have a nice day. See you later.
Thank you. You too.